accidentally the camera might fall on your laptop screen or formally begin. Recording. Okay. Welcome to Health and Wellbeing Board meeting on Thursday, 11th of May, 2023. A special welcome to our, thanks Wendy, our police representatives, an organization that has recently joined us. Thank you very much. It has taken a while to formalize your entry, so apologies for that, but we really look forward to your inputs and your presentation later. Okay, so we have started a new practice that we introduce each other, because every meeting we get new people, apart from some traditional attendees like me. So I thought it would be better we introduce ourselves before the meeting starts. My name is Paul Edgell-Shelvan, Councillor for South East Cramlington, and I chair these meetings.
I'm Graham Size. I'm a GP in Alnwick. I am clinical lead for the Northumberland part of the ICB.
Morning everyone, I'm Jill O'Neill. I'm Executive Director of Public Health, Communities and Inequalities, Northumberland County Council.
Wendy Patterson, County Councillor for Adult Wellbeing. Hilary Snowden, Government. Morning, I'm Karen Murray. I'm a Chief Inspector of Northumbria Police in the Harm Reduction and Communities Department.
Good morning, I'm Brian Mulder. I work at Newcastle Hospitals in the business side of the hospital.
Good morning, I'm Graham Writer. I'm the Director for Children's Social Care, Young People and Families.
Morning everyone, I'm Graham Binning. I'm the Deputy Chief Fire Officer at Northumberland Fire and Rescue Service.
Morning everyone, I'm Ashley Rice and I'm the General Manager for North Nighting Services Gateshead Northumberland for Harrogate District Foundation Trust.
Morning, Christine Wardlaw, Community Pharmacist representing North of Town Local Pharmaceutical Committee.
Good morning, Sheree McCartney, Group Nurse Director for Cumbria Northumberland Town and Mental Health Trust.
Zoe Charge, Policy Team Leader in Family Services at Northumberland County Council. I'm Kerry Lynch, I'm Senior Public Health Manager, here to present an item today.
I'm Leslie Bennett from Democratic Services.
Yeah. Thank you. Okay, so
Yes, it's apologies from Rachel Mitchison, Councillor Renna Thompson, Councillor Simpson, David Thompson, Councillor Watson and Claire Wheatley.
thank you. Can I sign the minutes of the previous meeting as a true record? Thank you. Disclosures of interest. Any interest? I see none. Thank you. Okay, so that brings us to the agenda item 4, which is an update to pharmacy needs assessment. As you know, we had the previous assessment report in September 22. This is going to be an update further in the light of so many closures of pharmacies, especially at Sainsbury's. So we look forward to hearing that report. Thank you. Floor is yours.
There are a few things that go with the paper, and that is some sort of ground rules for when pharmacies close. The Health and Wellbeing Board cannot stop a closure because it's a commercial decision that the pharmacy is closing. However, the Health and Wellbeing Board can make a judgment that the closure leaves a significant gap in pharmaceutical services. And what we can do is issue a supplementary statement to indicate the extent of that gap with regards to times, locations, and the services that are going to be disrupted. In previous life, anything from the last 15 to 20 years, if there was a sniff of a pharmacy being sold, it would have been snapped up immediately. However, due to the flat funding that community pharmacy has received over the last 7 years, so there's been no account of any inflation, any of the inflationary pressures of fuel costs, insurance, rates. The cost of actually employing a pharmacist have all gone up in the last 7 years. That's not to mention the lack of pharmacists due to them being pulled into GP surgeries to try and prop up the primary care services. So if you like, we have a perfect storm. I know that Lloyds have lost in their annual accounts at Companies House £66 million last year. And I think their parent company, which is a financial institution, have just said, get out. Because as well as this closure, all the other pharmacies in Northumberland that Lloyds has are up for sale. And most of them have found buyers. So we have an expectation over the next 3 to 4 months that there will be change of ownership of all the Lloyds pharmacies. And we're not the only Health and Wellbeing Board that is going through this. Lloyds announced in January that they were closing all the 237 pharmacies that it had in Sainsbury's stores. Since that time, it has become obvious that they are closing other pharmacies or trying to find buyers for them. And just to give a bit of perspective, the store in Cramlington does about 8,000 prescriptions a month and would earn about £2,500 a week from processing those prescriptions. But the costs of employing a pharmacist for 100 hours a week, or the 2.5 to 3 pharmacists it would need, would come to more than £3,000 a week. So that's before paying for any staff and whatever they have to pay, rates, pay to Sainsbury's for running the franchise, all the other staff in the shop, insurances, etc. So you can see that it's not going to be a particularly appealing thing for somebody else to come in and say that they would happily take that over. I think something else to think of long term is what sort of other risks Northumberland has as the likes of Tesco's review whether their stores are making money, as I think that would be even more awful for the populations. It would be an even bigger gap if Tesco's in Berwick and Tesco's in Hexham were to close. I know the people of Cramlington won't think it, but it is only 5 miles to the next 100-hour pharmacy. If Tesco's in Berwick close, we are talking about real problems. I think at that, the only other thing I'd like to say is that NHS England's appeal body came and did a visit in February to Cramlington and looked at what was going on in Cramlington. And this was due to an appeal from the Brockwell development. They have now been given permission to open a new pharmacy, but that permission is live for 2 years. So they've got 2 years from the 30th of March to open a new pharmacy, which is not going to get us out of a hole in a very quick time. What they did find was that the Lloyds in Sainsbury's was a normal size for a supermarket pharmacy, that Boots looked very busy and was obviously experiencing queuing at that time because they had ropes to guide queues. They thought that the Well Pharmacy, which is located in the entrance to the GP surgery, is unlikely to be used by people who are not accessing that surgery. And the Lloyds at Brockwell also looked busy and queuing. Other things to bear in mind is that the shopping centre is only open from 8 a.m. to 6 p.m. Monday to Saturday and 9:30 to 4:30 on Sunday. So locating a shop, even if we could find one, within the shopping centre would not address the out-of-hours issues. So the other thing that the appeal authority said was that they thought that 4 pharmacies processing 60,000 scripts between them was well above the national average. So I don't think there would be any problem in NHS England approving a further pharmacy following the closure, but it doesn't necessarily mean that it would address the out-of-hours issues. The other pharmacy that is available is the Pharmacy 2000, which is located in a business park in Cramlington. And being an internet pharmacy, they can't provide every service that a pharmacy would provide, but they can provide repeat prescriptions and do all their pharmacy deliveries in person. They don't rely on Royal Mail, so it is excuse me, a safe and secure delivery service. It might help bridge a bit of the gap with regard to capacity. And I think at that I will stop and take questions.
Thank you very much. I think it's very illustrative using a sample. Are there any questions? Alistair.
Thank you for the report, and I realise an awful lot of this is entirely outside your gift. I suppose several different bits. One is, I think, the great strength of the face-to-face pharmacy is around the reviews of medication, the compliance, how you take your medications, how you use your inhalers. And I do worry that an online model ignores all of those aspects to a large degree, and therefore this is not just about delivery of medications, and there are a lot of examples of online pharmacies delivering medications that are not needed or not being used, which is not a best use of NHS resource, and actually, more importantly, could compromise somebody's health. So I suppose that's one, but I think we are where we are. I suppose my second thing is if we look at a subject that's come up here a lot, which is around primary care access. An awful lot of the primary care recovery plan for general practice includes wider use of pharmacies. If simultaneously we have fewer pharmacies and actually pharmacies that are struggling to manage demand of prescriptions, to then give them the demand of managing consultations, which is what part of the recovery plan entails, also even down to the amount of available space in pharmacies for that, etc. We've almost got a collision of primary care access, of part of which is the solution is pharmacy access, of which we are seeing less rather than more. So again, outside your control, but I think it's really important that we, as a health and wellbeing board, kind of are cognizant of those, because part of the recovery of one is actually being impeded, which is a real shame.
Can I just come back on that and say we are not alone? This is being experienced by every health and wellbeing board, and I think it's something where strength in numbers and combined action is what's needed, because unless we get through that, there is a big funding gap. We are going to end up in a very difficult position. I know that the likes of Boots are moving more and more to hub and spoke approaches such that they can use factory facilities for the processing, with the giving out of prescriptions as much as possible down to local branches. But something needs to be done, and it needs to be flagged nationally, not just on this health and wellbeing board.
Yes. You want to come back?
Yeah,
last minute somebody might buy, so that closure might not go ahead. But with the change in the regulations, the 100-hour pharmacies are now going to go to 72 hours.
Right.
So are going to have that option. And I mean, to be quite honest, given the current financial pressures they're under, they're all going to go to 72 hours. Mm-hmm. So, you know, that's a given, really. So you're going to have the likes of Asda in Ashington, which is probably going to reduce their hours. You know, there's Central Pharmacy in Ashington. There's going to be, you know, a number of issues for the future to think about. I think when Anne talks about like Sainsbury's, the Lloyds and Sainsbury's doing about 8,000 items a month, predominantly the majority of them are going to be during normal like office hours, say 9 to 5 type of thing, 9 to 6. I think the gap, if any gap is going to appear, is going to be the out of hours after 6 o'clock till 11 when they would normally have been open. And realistically, we have to think about how many people actually are accessing those services when we think about a gap. How many of them are genuinely urgent need. So it could be that actually there's a small number of patients, and whether or not you know, the GP out of our service go back to where historically they used to provide a small quantity of emergency medication to get the patient over till the next day when a pharmacy was open. That might be something that needs to be considered. I think as well, like Pharmacy 2000's been mentioned, it cannot do any patient-facing services, so patients cannot like go and see a pharmacist. And so if a prescription goes there, realistically, they're not going to get the prescription for 24 hours at the earliest. I think one of the potential gaps is going to be the number of enhanced services that pharmacy is offering outside of normal hours. So obviously in the northeast we're quite unique in the fact that we have the new UTI service where women under 65 can access antibiotics for urinary infections through pharmacy. That's, you know, those are probably the data we need to get as to how many people are going out of hours for those services and how we accommodate that.
Yeah. Can I just say that I realised that this would be a big issue, and when I first went and had a chat to the manager at Sainsbury's, I asked her if she would be able to collect that information, you know, whether it was an urgently required script, where it had come from, just so that we could get a picture of what was going on in the out of hours. What she said was it was busy up till about 8:30, and then it would be real emergencies, more or less, if there were scripts or requests after that. She said she didn't have the time or the staff to be able to collect that information, so that's when I involved Healthwatch. And then they started closing at 7 o'clock, so that rather scuppered that plan, didn't it?
Yeah, there we go.
Jill, you want to come?
It was just to invite Derry to give us your response from a Healthwatch perspective, and then I've got one comment at the end, Chair, if that's okay.
That'd be great. Is there a clicker for the presentation? Lovely. Down to go on, right. Yes, thank you. Good morning. As you know, Healthwatch's remit is to ensure that patient and service user voice is heard in the planning and delivery of health services, health and social care services. And as Anne has just said, a change such as the nature of this one falls very, very squarely of something we want to be involved with. So we have taken the unusual for us step, completely within our remit, to actually use our enter and view powers given to us under the Health and Social Care Act to carry out a series of engagement activities within Lloyds, in Sainsbury's and Cramlington. What I'm going to give you today is an update. It's an ongoing engagement, but I think it gives you a really good flavour of what patients are feeling and experiencing and what their aspirations are for their pharmacy services in Cramlington. We've got two aspects, two arms to the engagement at the moment. We have an online survey, which is available through our website and through Facebook and Twitter and Instagram and all those places. But also, I have to say thank you to all the local elected members in Cramlington who have also been making sure that their residents are aware of the closure and the survey. The survey, a quick picture of it up there with the QR code with the rather cute little dinosaur in it, which you can use today if you're sitting there and want to. So, not going down. Could you move it on for me, thanks?
That's it.
So, as I say, it's we're using our enter and view powers. We are focusing on the out of hours because, as Anne said, it's very clear within the context in which this pharmacy sits, it's those shoulders to the service that are the really important things. So we've been doing these 4 activities. We've got another one this evening. I'll be up at Sainsbury's tonight if anyone wants to come and join in. We were going to be there later in the evening, but the pharmacy is now closing at 7, and I think that's really important for what we're hearing, and we're doing one on Saturday as well. Could you move the slide on for me? Thank you. So what have we heard so far? We have heard from 150 people. When the survey went live on the 28th of April, we had over 70 responses in the first 24 hours. I mean, people just clicked onto it, so it was really good. So we've been getting a few more over the weekend. Certainly on Tuesday evening, we heard from a lot of people. So what have we heard so far? We're pleased that 80% of people have actually heard of that we've spoken to have heard about the closure. That gives us some confidence that there has been some communication around this. People are picking up on it, because there's nothing worse than turning up and, the shutters are down. 57% of the people we've spoken to use that pharmacy for regular prescriptions. So you might think, well, it's just in the middle of Sainsbury's, people are going in, it's it's long hours, people are using it on that ad hoc basis, just when they've got the one-offs. Actually, no, it's people who've, the people who are there are using it on a regular basis. We're also very pleased that 66% of the people we spoke to know how to change pharmacy. Again, one of our worries was that this was going to happen and people were going to be left thinking, well, where do I get my prescription from? 31% said they will go to Boots at Manor Walk. And I'll come on to that in a moment. And I think there was another, I think it was about in the teens percentage saying they will go to the Well pharmacy. Only 5 people out of the 150 said that they would use Lloyds or another online service at this point. Now, given that in Lloyds, they've got the poster up saying we are closing, here's a QR code, go through for that, and you go through to their online service, I think that's probably quite significant and maybe something that we need to think about a bit further about whether that is people not wanting to do it or simply not knowing about it. Probably needs though. But I think in terms of ambitions, it's a really important point. 25% of people said they haven't even really thought about what they're going to do next. So again, we can't assume things are just going to go forward and it's just going to happen. And of the people we've spoken to, 33% during the weekday have said they go after 7 p.m. Can I have the next slide, please? And again, I think when we dig a bit deeper about why that is so, what comes out is that the biggest issue is about work. People are working outside Cramlington and then they're coming back to get their prescription, and that is really, really important to them, and that is an absolutely key theme that's coming out, that people rely on it for work. There's also an issue that we picked up that, as I said, 49% of people said they'd used it outside of the core hours. So there is, there is a reliance, there is a usage there. One of the things we picked up very quickly was that there are people in specific circumstances who having access to out of hours, especially the early morning, is really, really important. And one of the things that we've picked up is that people who are going to work but want to get their methadone script before they go to work. And that's a really important service. And I know that we've already made colleagues in drug and alcohol services aware of that. Massively important. But the other thing that was really coming out of that as well is that people are not using it because it's convenient. They're using the out-of-hours service because it actually makes their life easier. And I think that's a really important point, that we shouldn't just see this as it's convenient for them to do it. It is actually making their life easier. It's making people who have got, and I'm thinking particularly some people we've spoken to who have got very complex caring responsibilities and have said they go at the out-of-hours times because it is when other bits of their life have calmed down and they've actually got the ability to then go into the pharmacy and do what they need to do, pick up prescriptions, have a chat, those type of things. So we shouldn't just see this as, some people will go somewhere else because it's convenient. The travel to the 5 miles down the road is not convenient. And that is really important. I think the other thing that's coming out really clearly, and has already been mentioned, and patients absolutely clear on this, the pressure on the rest of the system, on the overstretched services, Boots, the queues at Boots mentioned routinely, absolutely routinely. So people are very aware of that and already saying, oh God, it's going to be more complicated, it's going to take more time. So yeah, really aware of that already. Next one, please. Just a few quotes there from what we've heard already. I just thought it'd be useful just to let you see what people are actually saying. Okay.
Thank you, Debbie. Yes,
Just one more
Alistair.
stop. I've got one more slide. Our ask at the moment, and you've seen this in your papers, and I think these two things have absolutely been underlined by our engagement. What is absolutely clear that is people are saying is that it's really important that, I can't spell professionals, I've just noticed, sorry about that, that the actual reality of what this means for patients is really well understood, and especially those in specific circumstances, and as I say, for carers as well. I think that's what's come out of our engagement. So that direct communication so people can prepare and understand. But I think what's really come out is the need for an equalities impact assessment. What does this really mean for people? Because I think there's an opportunity here that if we're not careful, we're going to design services for people to fit into rather than what we should be doing and what people want, and is for services that fit into their lives and support their lives. And I think that is really important, that impact assessment is done, and it's done from that perspective as well. So I think that's what we've picked up, but we will give a full report when we've completed the engagement.
Next.
I have no.
Okay, thank you, Debbie. Thank you. Yes, Alistair, you had some question.
Again, a really good report. I've got a conflict of interest on this, but the pharmacy in one of the surgeries I work with put a medicine dispenser so people can go get their prescription at 3 in the morning if they want, which is about the convenience around your working life for repeat medications, and there is also the physical pharmacy as well. And I think if we're looking at people's quality of life and other bits about the ability, whether or not we actually could promote more of those, because it certainly works really well, and it does give people the flexibility without needing the context of seeing the pharmacist, because it's all sorted, so it's repeats and other bits, but we need to be able to work around people's lives. But that might be part of the solution, and it certainly seems to be very popular amongst patients, where we've got, so it works really well, very safe, secure, individual pins, etc., to get the medications, and might help bridge those out-of-hours things. Obviously not for methadone, but for lots of other medications.
Please.
And you mentioned getting the data on the enhanced services that actually goes to the ICB on a monthly basis. So the pharmacists might not actually have been aware that they collect that data.
But we were specifically looking for the out-of-hours stuff, we can get the data on the number of interactions or services delivered, but it doesn't tell us what time of the day. And that was the important information that we wanted to generate for this meeting.
Thank you. Any other? Jill.
Thank you. It's been really helpful to get that level of detail, and appreciate you coming at the point at which it's still live as well, because I know that the plan is for you to come back in the autumn time as well once the reports are finished and we know more in relation to Brockwell and such like. I suppose just a couple of points. I absolutely agree around the Equalities Impact Assessment, because it is about those who are going to be disadvantaged the most, that we're most concerned about, and the likes of opportunities that Alistair's raised are really critical to potentially weave into future recommendations for us to still be able to manage that out of our offer. And I think just going back, Anne, to your point around this is a national concern, and lots of health and wellbeing boards will be discussing this. As a regional group of directors of public health, we are in engagement with our ICB exec to talk about this, because obviously pharmacies from the 1st of April transferred across to ICB. So, Graham, we are talking, aren't we, at a local level with Pamela Phelps and such like, but I think there's also a regional conversation, and potentially we can then take that into our National Association of DPHs as well to gain that support in relation to our concern that what's happening for our pharmacy colleagues, especially again when Alice has made reference to the primary care access and recovery plan, and it's just not aligning as best it could at this current point in time. So, thank you.
Yes, please.
I'll make one comment, straight question. The crux of the matter is that the pharmacy is not viable. It's not business viable. So it's not, if it was making money, we wouldn't be having this conversation. There wouldn't be closing. So what I'm supposed to say is this the sign of things to come? That people are using online pharmacies, people are shopping differently, that we have to think differently, the ICB has to think differently, nationally have to think differently. I mean, the old days, in the old small pharmacies, you used to go in there for your photographs and buy your shampoo and toothpaste. Now, that kind of doesn't happen as much nowadays. Now, the question for Anne, I suppose, with these 100-hour pharmacies stroke in a supermarket, if someone does go and buy the toothpaste, that money goes to Tesco and Sainsbury's, it doesn't go to the pharmacy. So are we creating, if you're relying on your NHS income solely, it's going to be very, very difficult for a pharmacy to sit in a supermarket and be viable.
Very good question. Anne, can you please?
When the way to get a pharmacy contract, because it's a closed market and you have to go through a particular process, it was way back 20 odd years ago that it was a solution to another primary care problem of access. When GPs were told they didn't have to do out of hours and weekends anymore, well, what we're going to fill the gap with? Community pharmacy. And therefore, the carrot was, if you say you will open for 100 hours, you can have a contract. So there was a proliferation of 100-hour contracts. And the supermarkets thought it would be a very nice thing to have a pharmacy, because the markup on over-the-counter medicines is higher than groceries. So, and they were going to be open anyway, because a lot of them are open long hours. So they thought, right, okay, we'll do that. Of course, it didn't work out quite as they planned because of the Sunday opening hours, such that they could only open for 6 hours on a Sunday, instead of the 12 hours that the government originally thought they'd be open, which is why you got these very early morning and late nights, which aren't the commercially viable bit to meet the 100-hour regulations. So it's the law of unintended consequences. So you've got this proliferation of what are now marginally viable pharmacies being labelled to close after 72 hours, I think might stem the decisions to close, because everybody says that apart from particular individuals, that the early morning, anything before 7:30, 8 o'clock, nothing much happens. And after 8 o'clock, 8:30 at night, not a lot happens. There isn't an emergency situation. So maybe the 72-hour regulation will stem the closures, but community pharmacy is on a knife edge. All of it.
All of it. Thank you. Any other questions? Thank you very much, and in fact, it was very informative. I am sufficiently informed and also moved to write to my MP as a member of the Cramlington Council, you know. And I'll also discuss with Glenn and Wendy after that, whether as a chair of Health and Wellbeing Board, should I write to Steve Barclay, the Health Secretary, or the Prime Minister, or whatever. You know, this is a big crisis. In fact, we in Cramlington, we are fully aware of the consequences of this. We are concerned about it, and you have thrown lots of light with your statistics and everything. Thank you very much. Thank you. Yeah, cheers. Okay, so let's move on to the fifth item, oral health strategy. I think Kerry Lynch, yeah? Thank you. Right.
Okay, let's see if it works. Okay, thank you. Yeah. Okay, thanks everybody. Lovely, thank you very much. Yes, my name's Kerry Lynch. I'm Senior Public Health Manager here at the Council, working in Jill's team. My item is quite short today. This is an information item to update the board following your agreement to extend the strategy period last year. We'd done a lot of work on oral health and oral health promotion, but like so many things, right in the middle of the first strategy period of 19 to 22, there was a global pandemic. So we were a little bit, not behind, but obviously it affected the oral health promotion work that we wanted to do. So Liz Morgan came and requested an extension, which you granted. So this is an information piece to say we've done some further work on that as a partnership group, and to ask for your agreement and endorsement to carry on the work. So that's what I've just said. So just a couple of key issues, and I say again thank you to board. I know you've had oral health on this agenda a few times, so I'm not going to go into a lot of detail about some of the data, because I know you're well briefed on it, but just for a reminder and context for this morning, oral health is, as you know, an important part of the overall health and well-being of an individual. It can affect people in different ways at different parts in their life, and particularly, if you like, those that we feel are most vulnerable. So children under 5, but also elderly people and older people later on. And that you know, if a child is experiencing decay, they need to have treatment. They might miss school. It affects educational attainment, and later on for older people, just that sort of having good oral health is crucial to general well-being. There's elements of dignity, etc., for later in life, so it's extremely important throughout the course. Oral health has improved considerably, and there are some areas in the UK now that are almost entirely free of dental decay, for example, in 5-year-olds. Unfortunately, we're not one of those areas, as we'd expect. We've got pockets of deprivation. We are focusing as a council and obviously as a system and partners on inequalities. And as I've just said, because of those vulnerabilities and the impact of oral health, this is really important for us around our inequalities work. The most up-to-date oral health survey of 5-year-olds shows that 16.7% of 5-year-olds in Northumberland had experience of tooth decay. But I believe that's an improvement from last time. I'm looking at Lucy because she's a data expert. So it's a positive picture, but it's not good enough. And like I said, the other extreme around older people, it's obviously a key issue. In our oral health needs assessment that underpins all of this work, we obviously noted that we have an older population in Northumberland, and that
that group of the population will continue to grow. So again, if we choose one indicator, we could look at oral cancer mortality for older people. We have a lower rate than our northeast counterparts in England. But again, oral cancer as the reason for death is something that we would really want to continue to look at and monitor. Now today this is not why I'm here today, because I wanted to talk about the oral health promotion and the work of the strategy group. But we are obviously very aware that there are some wider elements that impact on the work of the Oral Health Promotion Group and on our work trying to reduce oral health inequalities. And they are the two on the screen. So there's the access to dental practice, which I know has been discussed in relevant committees, and the fluoridation element. So I'm going to talk a little bit about them just for context. I know that partners are concerned and interested, and I know the elected members, you are having queries from residents, and I know Derry as well. So it's just important to put it into the context, but it has been spoken about in relevant committees. As a group, we obviously want to make sure we keep an eye on that and support colleagues and do what we can to inform and influence, even though they're actually outside of our council jurisdiction. So these are not mine. This is when I've watched the Health and Wellbeing Overview and Scrutiny Committee presentation that was on the 7th of March. I know Derek was there and maybe other partners. So I've lifted from that presentation that was given by NHS England, and there is work happening, and I know some of you are involved in that. But like I say, it was for context for today. In Northumberland 2021, 78.6% of the population were able to obtain a dental appointment if they wanted one. And that's slightly lower than the North East average, and may well have been impacted by COVID. And like I say, I don't want to talk about it because it's not mine to present, but it is there, and certainly we can field any questions that we can. The responsibilities have transferred to the ICB now. We're in touch. Pamela Phelps is busy. We've been in touch with Pamela Phelps. There's a meeting, I believe, locally to just take stock of this. So we'll keep contact with Pamela and colleagues in ICB to make sure that we are aware of it in the context of the oral health promotion work as well. And then the fluoridation, again, I know we've reported before that the responsibilities for consultation on variations or introductions of community water fluoridation schemes have changed. They're no longer ours, and they are national now as the responsibility of the Secretary of State. Directors of Public Health, myself on Jill's behalf, we will continue to seek clarification on that and time scale for when national consultation will happen. Because as you know, some point last year, Secretary of State did announce that they would consult on a North East scheme. I was just at the meeting yesterday, so it's hot off the press, I'm looking at Jill, and I did press national Department of Health colleagues for a time frame for that. Said autumn, and I said, what's autumn? So she said it wouldn't be before September, but that will come round very quickly. So colleagues, other representatives of public health from the other authorities that were at that meeting, obviously we've offered our support. We did a lot of the work here on that, and we were just about to go to consultation. So we've got lots of learning, and certainly we don't want to reiterate and kind of go over some of that old ground that we as a council and as a partnership have already done. But I did want to remind us that we do support fluoridation as part of the reducing inequalities approach that we've got. It is a crucial measure for the health of our residents. So again, I've said that Jill and I on her behalf will continue to keep you up to date with that. So back to the oral health promotion background. Like I've said, approval to extend the strategy period was given last year. We have a partnership group, and it's very well represented. We only meet twice a year, and actually we meet remotely. It was one of the good things that came out of the pandemic, that actually that group, it includes clinicians from the LDC, etc. They can dial in much easier, so we just meet remotely twice a year. But we do quite a lot of work. The group has looked at the strategy and started to develop a new action plan. I'm going to just highlight some of the things that are in that. Much of what was in the previous plan is in the new plan because we want to continue with that work, but some of it also is new and is in development. So, for example, an existing action that, again, I think board was interested in last time was around the delivery of oral health packs, so toothbrush and toothpaste to vulnerable people in our community. And I know we specifically were talking about food banks. So that happens. We still continue with that. Packs are distributed via the food banks every 3 to 4 months. So what we want to do is kind of really evaluate that, make sure it's happening, continue and expand that sort of approach. It's very well evidenced as well, giving direct kit, if you like, to vulnerable families. And then there's new things in development around training for carers of adults with learning disability and development of a particular oral health, making every contact count module. We'll continue to meet twice a year, I've already said that, and we'll report. So I'm not going to go on. This is the data update. As you would expect, we've also looked at the data in the old strategy and updated that so that it reflects the most current stats, and I've already mentioned a couple of them. Again, there's reference in the new strategy around the change responsibilities that I've already mentioned as well. So this is just a selection, and when the papers were sent out, you had the brief paper that I've written, but also the draft action plan, so that's where all the detail is in. It is at the stage where I wanted to present and get any steer and feedback from yourselves as a board. Anything that I hear today that you want me to look at and present to the group, I'll take to the group and we'll update, and that'll be the sort of final ratification, if you like, and we'll get on with the business of it. The plan is sort of separated into themes. So as you would expect, the previous plan had improving oral health of children and young people as a key theme, as I've mentioned, especially with the under 5, so best start in life. Improving the oral health of older people, and again, I've mentioned about the kind of the dignity and the well-being of older people, for example, living in residential care. Partnership working, and I've talked about how we don't have the jurisdiction, but we have the influence in partnership working on some of those bigger issues, and service development and commissioning. And a good example of something that's hot off the press around service development is now, and we because of the partnership, it came to light that looked after children weren't getting an automatic referral to the community dental service in the trust. So now they are. So that's an excellent kind of hot off the press service development issue. And I'm suggesting we're going to add in another theme this time around improving the oral health of vulnerable groups. Obviously, some of those vulnerable groups are children and older people, but we felt, and we've got some representation in our group from Kathy Peterson and from ICB, and who's also a GP, is really interested in learning disabilities and that sort of thing. So I think it's important that we maybe focus on vulnerable groups that don't fit into those age categories. So again, we've got some examples of the work and there in that theme. So that's it. It was just to say there's still a lot to do. I'm really assured that board are interested in that we've had a regular slot on our oral health for this committee. We as a group say that much of your organisations are represented on the oral health strategy group. We'll continue to do the work with your sanction today. Thank you.
Thank you very much, Kelly. Thank you. Any questions? Okay. Wendy.
Thank you, Chair. No questions, just to thank you very much for this very important report. And actually this morning, I think we've had 2 very valuable, and I haven't got my microphone on. He turned round and just made me aware there, I think. I just want to say we've had 2 very important presentations this morning which really do affect all of our health. And so I just think the meeting today has been really crucial.
Alistair. Thank you.
Apologies, I'm saying a lot this morning. It was just this, we talked about health inequalities around pharmacy, and I suspect if we look at oral health, particularly those children and other people who are affected, I would bet a fair amount that there'd be more deprived communities that have the worse level of caries and etc. And if we look at food banks and things like that, is there a way that we can weave inequalities into to this more overtly, I suppose, was one of my thoughts.
And the answer is yes. Yeah, we can certainly look at that in the group, kind of tying that inequalities and putting that thread of being a bit more explicit about the matching of those activities. Yeah.
Yeah. You are right, Alistair. There is certainly a correlation between oral health inequality and the deprivation. Except that in Hartlepool, I was reading your report carefully. In Hartlepool, they seem to be having a better oral health compared to many areas of Northumberland. It may well be due to fluoridation. Yes, yeah, natural fluoridation. Yeah, fluoridation. Sorry, I'm not saying the word properly. Yeah.
I heard from the very technical water committee that I went to yesterday that talks about the plants and the levels of chemicals in the water and stuff, that they have to actually dilute the water in Hartlepool because of the natural fluoridation.
Okay, fluoridation, yeah.
So
okay, yeah. Thank you. Any other? Yes, Graham.
Who knew?
Yeah, so just to confirm the point, that actually I've been doing work with colleagues in the RCB and across the Trust to strengthen the dental pathways for children looked after, which is really positive.
Thank you.
You wanted to say something as well? No. Any other? Yes, Derry.
Yeah, I mean, obviously you've set out quite clearly that the availability of dentists is only a contextual issue to the strategy, but I think it is an important strategic consideration, because obviously people's confidence in their ability to visit a dentist is lessened, isn't it, with their experience of the difficulty of getting an appointment. So I think it's something that we probably will want to keep in contact with you, so that you are aware of that, and quite pleased to see some of the things that are in the pipeline. Yeah. But I think we shouldn't take our eye off the ball in terms of the effect of that lack of access could have on knock-on effect for the strategy.
Yeah.
Thank you. Yes, Jill, final word.
Thanks, Kerry, as always. A fantastic presentation, and thanks back to the group as well for all of the work that they're doing. The inequalities point is always really well made, and we know that actually the community water fluoridation scheme would be one of the most foundational things we can do to close that gap, because we know that those in our more deprived communities will benefit the most from that fluoridation. With permission, Chair, it would be good once we know more at a national level in relation to how the consultation is going to get rolled out and our part to play in that as a Health and Wellbeing Board. It would be good to bring that back and have a further conversation.
Thank you. Sure. Thank you very much, Kerry. Now to agenda number 6, Northumbria Police presentation by Karen Murray.
Lovely. Thank you very much for the invitation today. As you can see, I'm not Claire Wheatley. Claire Wheatley unfortunately was detained today. I've worked with Claire Wheatley for quite a lot of years. I am very, very passionate about this area of business. I've been in Northumbria Police for 28 years. An awful lot of that in neighbourhoods where, being blunt, I've been quite frustrated about the mantra that the police do the persecution, if you like, or the trying to catch offenders and not taking a public health approach. My interest in the public health approach has been something that I've been working on for a lot of years. Actually worked with Kim McGuinness when she was a councillor in Newcastle, and had many a long conversation, because she was the councillor and I was the police neighbourhood inspector, where we were talking about the issues in relation to crime and antisocial behaviour. And what we were trying to do at that point then was implement very much a public health approach and making sure that it was a partnership approach to reducing crime and disorder, because there was that realisation that we can't police our way out of this. So this presentation really is to give you some background into where we are now as a force, on our journey around that supporting that public health approach and that preventative approach. So nationally, obviously, we take direction from the Home Office, and on the back of the Home Office, the Police and Crime Commissioner creates the policing plan. The police and crime plan is something that she devises in conjunction with our Chief Constable, and the objectives are fighting crime, preventing crime and improving lives. It's probably the improving lives bit that maybe surprises people a little bit, because they think of us about the fighting crime and the preventing crime, and historically perhaps an awful lot of our time and attention has been on number one, which is the fighting crime element. You know, if you go back to the Peelian principles, the development of policing in the first place, it was actually the middle one. It was the preventing crime was our focus, and then over years it moved to fighting crime. And actually, what we're trying to do now is say, actually, it's all three, and we're trying to make sure that the weighting of all three is appropriate, because the reality is to get ahead of demand in relation to our frontline services, we have to be looking at the improving lives. And that has to be a fundamental part of every strategy, every delivery plan, that every operation that we do, there has to be an improving lives element of that on a from a strategic to a tactical to a practical operational level. The Police and Crime Plan is available online. Anybody can get access to that, so we didn't provide a copy here. I actually work in the centralised harm reduction and communities unit. We're actually in the process of probably changing that name. I don't know exactly what the name's going to be called, but it's going to be something along that preventative, because people misunderstand. When we start talking about harm reduction, we often get a lot of quizzical looks going, what's all that about then? Whereas if we start talking and using language that other partners use, which is around prevention and early intervention and a public health approach, actually people better understand what it is that we're trying to do and understand. Like I've heard this morning, you know, some of the data that you've talked about today, it's so correlated to the same data that we look at. You know, when we're looking at data in relation to our highest harm areas where we've got a higher level of serious violence or a higher level of antisocial behaviour, I'm very, very confident that we're talking about the same areas. And actually that causes of the causes, what's underpinning what we see as behaviour and attitudes is some of those inequalities that sit underneath that. So these are some of the areas that we take a strategic lead on. That's not to say that these are the only areas. What we do is we engage with and consult with every area in our organisation. So, for example, the strategic lead for drugs and alcohol is developing their drugs and alcohol strategy, and we sit with them and we'll make their life difficult because we make sure that there is a preventative approach being applied to those strategic intent and those strategic priorities. So ultimately, our aim is to have fewer offences, less demand on policing, and we can only do that by addressing the causes of crime and utilising partnership. I don't know if you're aware of how policing is, I suppose, overseen, but we have the HMIC FRS, which is our inspection body, and Tom Windsor made a comment quite a few years ago in that, you know, as I said earlier, we can't police our way out of this. It has to be done in partnership. So very much now our inspection regime is focused on what are you doing to work in partnership in order to manage crime, to manage demand, and to make sure that actually we're addressing some of those inequalities. So I think sometimes in the past, policing are quite proactive, and what we do is we step into space that we probably shouldn't be stepping into. And actually what we should do is we should be better consulting and collaborating with our partners and making sure we get the right care for the right person, rather than us trying to stick a plaster on it. And it's about making sure that people are safe, but making sure that actually the right coordinated approach is taken to give people that real support that they need at the right time. there is a national prevention strategy. So yes, we get the direction from the Home Office and we get the police and crime plan, but nationally there is a prevention strategy. And this is a fairly new development, that there is a national strategy for prevention. It's Serena Kennedy, who's the Chief Constable, I can't remember which force it is now, but she's been given the responsibility of overseeing nationally the implementation of the strategy. So what sits under that is there are regional coordination groups, and our region is obviously the North region, South Yorkshire, Upover, and we meet, and I attend that meeting, and we meet once a month where we talk about best practice. We share what's happening in South Yorkshire, we share what's happening in West Yorkshire, we tell them what we're doing, in order that we can try and learn from each other and look at how the partnerships are developing across the north. And then we get the information from the other areas as well, in order that we can try and say, that's a good idea, why don't we try and do that? And have those conversations with people like yourself to build on that good practice. So the strands of it are cultural change, reducing harm, reducing offending through problem solving. Cultural change is a big one. We need to get it into our officers' minds that when they attend an incident, and I'll give you an example, and this is an analogy I use quite often with officers. If you're attending a burglary, your focus shouldn't be on the burglary. Your focus should be on the individuals who are suffering as a result of that burglary. Make your response person-centric. In doing that, your investigation into the burglary will naturally come. But if you try and understand what's made that person vulnerable at that point, is it their location? Is it their personal vulnerabilities? Is it other situational factors? And then look at what it is, problem solve it at that earliest point in order to try and make sure that we refer on, if need be, or give advice as appropriate, so that actually we are trying to reduce not just demand on our own service, but demand on other services as well. And that's quite a significant, it sounds minor, but that's quite a significant cultural shift. Because for years, particularly during austerity, we've been very focused on the operational solved burglary. And yes, solving burglary is important, actually identifying offenders and then managing offenders, but managing offenders in a long-term solution-focused way. So that's not about only focusing on putting them in prison or putting them on offender programs, but actually it's about looking at causation of why are they offenders? What's in their life that's causing them to resort to offending behaviour? Because quite often that is not, it's quite often the things that we've talked about here today. It's inequalities, it's poverty, it's lack of housing, it's lack of educational, lack of job opportunities, it's lack of community contact. It's those kinds of things that help to manage offending behaviour and bring down crime and make, well, getting back to it, improve lives. It's not just about improving lives of the general public, it's not just about improving lives of victims, it's about improving the lives of offenders as well, so that actually they have a better life and don't need to resort to offending behaviour. But like I say, cultural change and getting our officers to understand that as a philosophy, and that's an approach that we now need to take, is a journey that we are on. I'll come on to one of the things that we've nationally been recognised as something that we're trialling here that seems to be working well to help support that. So under primary prevention, just briefly, obviously we've got just talking to a colleague over there from Fire Service about our Prevention Through Education team. So our Prevention Through Education team work very, very effectively with the Fire Service around developing intervention education programmes for schools. And we take a tiered approach to that education. And what we do is we have material that people can self-serve, so they can go and get it online and they can look at it, and parents can look at that, and teachers can look at that. But in a targeted way, we look at the data and we identify areas where schools need more support. And what we then do is we provide them with that additional support. And some of that is inviting them to Safety Works, and Safety Works is a carousel of service providers, of which the police are one, the fire service are another. You've also got A&E, you've also got Nexus there. There's actually a half a metro train in the centre. There's a custody area and a front office there, so there's a park there. So it's a very immersive learning environment. And what we can then do is try and take that proactive approach to education in line with the data, and an awful lot of that is in the areas that you're talking about. In addition to that, we've got designing out crime officers. We don't have very many, but again, what we like to do is take a tiered approach, and we're just reviewing all our material in relation to that. And that's trying to, again, make sure that the public have access to information if they need it, so that they can take steps, sometimes at no cost, sometimes at low cost, and sometimes there is cost involved. And clearly, the engagement with yourselves, the Health and Wellbeing Board, is absolutely essential in order that we look and learn from your data, we look at and learn from the experiences that you're having, in order that we can try and understand that and support the underlying principles that you have, which is about improving lives, to make sure that we're all working to support that same objective. In secondary prevention, we've got diversion pathways. We have a number of diversion pathways, some of them linked to things like YOLO, which is You Only Live Once, which again is a nationally recognised programme that started here in the North East, which is a support programme for young people on the periphery of knife crime. So this might be somebody, for example, a young child who's taken a knife into school and it's in the bottom of their bag, and they're doing it because they're in fear. You know, what we then do is we work with them, and rather than giving them a criminal prosecution, we engage with them and we refer them through to one of the 2 football foundations, and then they go on a 20-week intervention programme with the football foundations. And some of that is about re-education, but some of it is also about working with the parents and working with building their trust and confidence in a trusted adult, and also making sure that they've got those links to community, so that they have other options rather than carrying a knife for fear and for protection. And that's just one example. There are a multitude of other diversionary pathways. The one I mentioned before, which is the one where there's a lot of national interest in, is our Signpost of Service app. So one of the issues that we found as officers is that frontline officers are attending incidents, and they're speaking to Mrs. Smith in relation to her antisocial behaviour. And in conversation, they find out that Mrs. Smith is also bereaved because her husband died a year ago. But if you don't know who you're referring to, if you don't know who it is that they can get help and support from, it's very difficult to then signpost them to the right service. So what we took the decision to do was to work with our partners and develop an index of services, and we have that index of services. It is at the minute only at a local authority level. So Northumberland Local Authority absolutely is part of that Signpost of Service app. And what we do is we give all of our frontline officers access to that app. So when they're at the scene of an incident and they're speaking to somebody, and they find or somebody divulges information where they say, I need help, not only are we doing our normal statutory referrals into the likes of the multi-agency hub through adult concerns and child concerns, we're also saying, here's some local services that you yourself might want to make contact with. And that can be anything from, like I say, bereavement services, it can be drug and alcohol services, it could be domestic abuse services, it could be health services. And we've consulted our lead partners in relation to all of that. Just before I came today, I did have a quick look. In the month of April, across our force area, we referred 2,126 people to other services. That's at the point of initial contact. They've got to consent because they've got to ask they've got to want to engage with us and give us some information. And they've also got to give us an email address so that we can send them an email with the links to those services so that they can consider doing something about that. In Northumberland, there was 410. It's very new. We only launched this in January, and we've not launched it right the way across every department. But it is absolutely in our response teams and in our CID teams. In particular, the services that the public in Northumberland were asking for was domestic abuse services, mental health, citizens' advice and family support. But again, we can liaise with you and provide you with more information and data in relation to that as that develops. In relation to tertiary prevention, we do, obviously secondary prevention, we do engage, like we're engaging with yourselves at the Health and Wellbeing Board. We also engage with the safeguarding boards in order to try and make sure that we've got that holistic intervention. In relation to tertiary prevention, we do an awful lot of work here with the likes of the Violence Reduction Unit, and we work with them to try and be innovative around some of the solutions, and there are emerging co-location hubs in place. One of the hubs here is in Ashington. Obviously, there's some excellent partnership work as well going on in Blythe, which are two of our highest harm serious violence areas. And what we've got going on there is some focused deterrence work. So this is where we're identifying young individuals, normally under the age of 25, who are on the periphery, and what we're trying to do is change that trajectory by having a dedicated individual. So it builds on the principle of offender management, but before the offence is committed, and tries to put in a partnership approach to make sure actually that trajectory into criminal justice actually is skewed, and it's a different trajectory. We're seeing some quite significant successes with that. That does not mean to say that somebody goes from being a serious violence offender to being a paragon of virtue and never committing another offence. But there are degrees of disengagement with that attitude and behaviour. As an example, I know of a particular case where there's a young man who is in a peer crime group. So this is just under the threshold of an organised crime group. So the trajectory is they're going towards an organised crime group. And normally does not engage with any services whatsoever, normally does not engage with the police, would either run away or shout obscenities at us, is now, through the focused deterrence work, engaging with services, and his mum is engaging with services as well. So it's about, I suppose, taking that, and some of you might know of it as Safer Families, it's taking that targeted approach and trying to work productively with families in order to change and improve their life chances. So some of these, I think I've already mentioned, but early intervention is absolutely key. That's what we're saying, is in order to get ahead of and deliver our objectives and to get ahead of demand, is we need to do that early intervention. And to do that, we have to work collaboratively with yourselves and with other partners. Changing that mindset to make sure people have got that professional curiosity, inquisitive nature to try and understand, why am I here? What is the cause of somebody wanting a service from the police? We also liaise with the Police and Crime Commissioner around Safer Street funding in order to try and make sure that actually we use that as effectively as we can, both to deliver that police and crime agenda, but also, like I say, the agenda, the vision and the priorities that you have. I'm just going to quickly touch on the serious violence strategy. So the prevention strategy, underneath that sits the thematic strategies for different areas of business. And as you can see, people might, and the reason we've picked serious violence to talk to you today, is that people might think serious violence, the police's job there is all about prevention. It is, we are about prevention, but all about protection. But prevention is a really big part of what we need to do in serious violence. And so it's using things like the money we get from the Home Office through GRIP funding to make sure that we have got high visibility patrols in the highest harm areas so that we can engage with the public to try and give them that public reassurance, which gives us then the breathing space to work in partnership to get underneath that causation and try and make a difference in those areas to try and drive down serious violence and improve lives. One of the bits of work we're doing, particularly in relation to serious violence, is a neurodiversity screener. Now, I could go off on a tangent with this one, and I'll try not to, but the national vision from the Home Office is that they would like to see a neurodiversity screener linked to the criminal justice system. I've got a bit of an issue with that because I don't think, you know, the criminal justice process by its very nature causes people to be in fight or flight mode. So engaging with a neurodiversity screener in a meaningful way, whilst you are part and parcel of the criminal justice process, with a criminal justice professional, for me is not the right approach. So what we're doing here in the North East is we're trialling a slightly different approach. So we are identifying individuals who are part of the criminal justice process, but what we're then trying to do is signpost them to one of our partners so that one of our partners can work with them in order to try and better understand the causation and the causes. And part and parcel of that is that we offer them a neurodiversity screening tool, which is called the Do It Profiler. And the Do It Profiler has been used in prisons and young offenders institutions for a good 20 years to positive effect. In order to try and identify if there are some underlying issues that we need to address. I must stress, though, that this is not a diagnostic tool. It is an indicator tool only. So what it does is it identifies an area that somebody is struggling with. It gives some ideas on how to develop some coping strategies, but it also then means that the partner can strike up a conversation with a professional to say, can we look at this in a bit more detail, please, because this actually might need either social care, education or health support. Without that tool, we wouldn't have known that. So that's something that we're trialling in the North East. It is being used in the Northumberland area, particularly by the Youth Justice Service. I am working with a couple of the other local authority areas to try and get it embedded or trialled in with the drugs teams. So I would welcome an opportunity to have a conversation with somebody in Northumberland about how that opportunity to use that tool could be moved forward. And I think that's about it. So I think just to say, we're all on the same page. We're all trying to do the same thing. You know, it's the public are the focal point, and the issues that you are having and the drive and the vision that you have is a vision that we share. Thank you very much.
Thank you, Karen. Thank you very much. And I think you've given us enough information to see where we all fit together in the big, jigsaw puzzle. Thank you. Are there any questions to Karen? Yes, yes.
Again, it's more common. Absolutely agree with the approach, and I'm also chair of the Youth Justice Board. And we've just had a Youth Justice inspection, the outcome of which we don't know yet. I won't find out till the end of the month. But absolutely, and very happy to share the outcome of that when that comes to the board, because it will show the effectiveness of our early intervention and prevention work around youth justice. So, for example, the number of first-time entrants into the youth justice system is significantly reduced. So we're managing to look at processes by which we can divert them from the criminal justice system and work positively and proactively to meet their needs to prevent future offending. So a lot of the information and data we have and the scrutiny that we put in through the multi-agency partnership Youth Justice Board actually rings absolutely with that, and the partnership working, I think, in Northumberland around that and early intervention and prevention around youth justice is really effective.
Thank you. You have any question, Graham?
Yeah, thanks, Chair. Thanks very much for the presentation. I think it's a moment in time for this board to have Northumbria Police as a board member. We're a relatively new member as a fire and rescue service, and we are happy to offer the challenge of what we all offer. And I think there will be challenges to to define, and I spoke with Graham earlier before we came in, how we are actually delivering against asset-based community development, how we're using our collective data sets, joint strategic needs assessments, etc., to identify the areas that we need to be focusing on. And then when we do focus, we focus in the right way, and we invest the communities and the people within those communities in the decisions that we make. I'm not totally confident that we're doing that yet, but I think we've got a commitment to do it. I've met in the past 2 weeks, I've met Vanessa Jardine, the new Chief Constable, and I met with Sam Rennison, the Chief Superintendent for the North. There's some laying out and understanding of what we're trying to do and actually how we're doing it. So we're absolutely on a page that we want to do the right thing. I think we've got some dots to join up, and it'd be good to get a chat off table about some of what I think next steps are. Sam Rennison, I think, has made a commitment to be a full member on this board, and I think she's the right level to be here and to be able to be challenging herself the way that I do about what do we actually take away with regards to what outcomes we want to achieve. I've got one of my key officers in the gallery today to make sure that we are connected with what we talk about at board and what we deliver in action. So thanks very much. Thanks again.
No worries. Perfect, Graham. Thank you. You want to respond to that, Sheila? Yeah.
Thank you, and it's absolutely fantastic to have you here, because I know that a lot of these conversations do take place in safeguarding partnerships and also in Northumberland Safer Partnership, but to have the prevention and early intervention conversation at Health and Wellbeing Board from yourself is great. And as Graham says, just trying to reflect that wider partnership of the Health and Wellbeing Board brings a different conversation to the table, which is tremendous. I suppose this will lead nicely onto the next agenda item as well, but I suppose I do have one curious question around the signposting, because obviously there's a lot of us that do signposting and service referrals. So it's around that workforce development and training and the making every contact count prior to just that referral. So I don't know if you can just expand a little bit from an assurance perspective that that brief, meaningful conversation is happening in addition to the signposting.
Yeah, absolutely. I mean, like I mentioned before, that approach and that philosophy has been coming and being built upon for quite some time. Like I said, Tom Windsor mentioned it in his HMIC report a significant number of years ago. There is actually a national vulnerability strategy as well as a prevention strategy. I just didn't want to over bamboozle you with how many strategies we've got. But part of that strategy is about how we educate our staff to take that person-centric approach. So we actually developed a vulnerability matters package for our workforce. That was actually delivered during COVID. Myself, from a public health approach point of view, were quite instrumental in the development of that package. And we consulted the OHID. So we consulted OHID in relation to the development of that package. And that started I suppose that conversation with staff around, well, okay, I get it, but how am I going to deliver that? I want to do it. I want to be the person that helps and supports individuals. I can see now that, Mrs. Smith, who I'm dealing with for antisocial behaviour and trying to solve that problem for her, but actually I can see that bereavement is the thing that she really needs help with, but I don't know how to get her that. So on the back of that, that's why we started to think about developing the SOS app. And then when we actually had a product that we could share with them, we tested it in Northumberland first, and we deliberately tested it in Northumberland first because of the geographics of Northumberland, to make sure that it worked and it was effective. And we briefed our staff in advance and said, you asked for this, you said that this is what you wanted. So let's show you how to use it, and then we tweaked it, and now we're in a position to roll it out wide. So it's a staged and staggered process. The reality is, though, the app is only as good as the content. So my department, the Prevention Through Education team, part of the role and responsibility of that education is to make sure that the content is accurate and up to date. The app is up to date within 10 minutes, so I can make changes to it now, and in 10 minutes it's live. I can get data within 10 minutes. It's not, you can probably tell by the way I'm talking about it, it's not a police IT system. We have commissioned somebody else to do this. It's actually a company called Nutshell that do it, who are a specialist in app design. And we're actually demonstrating the app to Durham in a couple of days' time. There are a number of other forces that are interested in it. And it's that functionality of it. We are looking at whether or not actually this becomes a multi-agency app as opposed to just a police app, because the reality is you could be sitting in early help, you could be sitting in social care, you could be sitting in pharmacy, you could be sitting anywhere. If you are a public-facing organisation, then sometimes you can't offer all of the help. And I completely get the one door. You know, you don't want to overburden individuals who potentially already have quite a number of services involved in their care. It's about making sure that you get the right care for the right person. So this is not about just bamboozling them, flooding them, with 15 different agencies. But the reality is, for an awful lot of the people that we come across, we give them lots of contact with statutory services, and the reality is they don't trust statutory services. We are the last people that they want to speak to. They speak to us because they've got to, in order to either not go to prison, not get their children taken off them, keep the house, whatever else it is. What we need to do is actually make sure that they have a contact with somebody that they trust. And it's that's the signposting bit. It's making sure that they've got somebody to go to that can then advocate on their behalf with all those different other services that they potentially are struggling to coordinate. I hope that answered your question.
Absolutely, yes, thank you. And I think there's a conversation that we had with Thriving Together as well, because they've got a frontline directory, so it's just trying to make sure that that's all joined up as well.
So what we do, actually, on the SOS app, because I'm very aware, and the frontline directory is very, very good, in the training that we gave our officers, we said to them, if you're in Northumberland and you've spoken to Mrs. Smith and she's told her that she's suffering from bereavement, absolutely signpost her to bereavement, but also signpost her to frontline. And the reason for that is Mrs. Smith might not have told you everything. So she's told you what she's prepared to tell you. So she might have said, I'm suffering from bereavement. Actually, she might have got a new partner and be suffering from domestic abuse, but she didn't want to tell you that. So if she goes onto the Frontline app, she can find some support services for domestic abuse, and then she can self-serve to domestic abuse. And it's knowing what we're trying to do is Niven Reddy, who is the director or was the director of the Scottish Violence Reduction Unit, he said it's about nudge theory. It's about trying to nudge people to take action themselves. And by doing that signposting and then allowing them the freedom to pick which service they want to engage with, and then them to do that, you are much, much more likely to get positive engagement and more likely to get positive outcomes. So 100%, that director is brilliant, and we absolutely do signpost people to that.
Okay, so I have few comments. Actually, I completely agree with you. This multi-agency cooperation is very important to get this the problem sorted out. In fact, we started that in Cramlington. Actually, we work closely with the Inspector Jonathan Casely.
Yes.
Yeah. So we often found during the off-term break, the antisocial behavior goes up. So as a town council and also using Concordia, which is a county asset, we have developed lots of programs for young people to go and spend their time. And in the recent years, we have found there is a dramatic drop in the incidents, awful incidents. And also, we were I think the police out there was focusing on gang culture. That's something that we need to be very careful of, because the gang culture gives a wrong model to younger people, because they look at their seniors operating as a gang and then they try to emulate the same thing. That's very important. And also it distracts people from education. Early education is very important in this modern world, in the information era. It's very important. What I want to know specifically is that and also fire service, do you go to schools and do some presentations or something, or would you like to? That's one question. The second thing is that I also chair voluntary organizations, since you are talking about signposting and people don't trust statutory organizations. You can also come and give a presentation there as well. There are lots of voluntary organizations you can talk to in order to signpost. I think people are more likely to open up to voluntary organizations rather than statutory organizations. Mm-hmm. This is completely up to you, actually.
I'll answer the first one first. So in relation to the schools, yes, we do, but we only have a very small team. And that's why we take a tiered approach to that schools intervention. So what we are looking to do is develop a catalogue of these are the, because there's actually a significant amount of information already in the PHSE section of the curriculum that advocates for an awful lot of these approaches and the information that we need to share. But what we do is we look to supplement that by providing a resource. So we have contact with all 660 schools across the Force area, and quarterly we send out a newsletter. And if there is anything in the interim that we feel that we need to share with them, then we do so. Yeah. As an example, I would say to you that in the back end of last year, we were approached by one of the thematic leads around cybercrime and sexual exploitation, and there was clearly an emerging pattern around young boys in particular being subject to or accessing material on the dark web in relation to pornography. So we can't develop a package to deliver to young people about dark web pornography, but what we can do is develop educational material for schools, for practitioners, and for parents, so that they're better aware of and understand the risks. And that's the approach that we took. So it's not always about standing in front of a group of children and delivering an educational input, because actually there's a significant amount of evidence that says it doesn't work. However, working with young people in small groups, which by its very nature is more time consuming, is more effective. So what we do is we take that targeted approach and we target those areas that are in our highest harm areas. And sometimes it is the specialists in my department that deliver those inputs. Sometimes it's our community engagement officers. Sometimes it is our neighbourhood policing staff. What we try to do is make sure that whatever it is that we deliver is professionally prepared and appropriate, in line with the age group that we're trying to present it to. And I know the fire service have a similar.
Yeah, happy to come in on that. I think another example of where I think things can join up even more. So your fire service in Northumberland has a full schools education programme that runs 12 months of the year. So the cycles of half terms and summers and bonfire nights are all factored into what we educate young children. We also have the Extinguish programme for children, young people showing a propensity for fire setting. So that brings in your crime element that I would suggest we maybe don't join up like we could at the moment. We have our Fire Cadets project, and we also have our Prince's Trust team programme. So from all young people up to adult age, we have an offering there. Your Fire and Rescue Service in Northumberland has that. I think, going back to the comment I made earlier, if there are messages or target areas that our services can come together, I think we need to explore that. And I think that also sits firmly in the inequalities agenda, the priorities and the asset-based community development. It all sits within the same paradigm. So,
thank you.
And I suppose just to add to that, a bit like the fire service, we also have the cadet programme. This year we took the stance of actually we targeted our cadet recruitment into some specific areas in order to try and build that trust and confidence and try and improve the lives of some young people in those areas. We've also got the young police as well. So in relation to your second question, which you're going to have to remind me about, I forget now.
In the sense that I also chair voluntary service liaison communities, and the Citizens Advice Bureau will be there as well. So if you want to have some signposting opportunities, you are very welcome there as well.
That would be brilliant. I would more than happily, put if I can share with the board the information that we need. At this point in time, we're only doing it on a local authority level, so it's not ward based. So it's not a service particular to Ashington or particular to Blythe or particular to Hexham. I get the complexities of that with Northumberland, which is why it was so important that we had the frontline directory included. We are looking to build on that, though. It's being consulted upon now at the minute at a national level in relation to actually, should that directory be a national directory, should it be made more available to partners as well. But more than happy to take some recommendations of what services you want to see in that app.
Okay.
Thank you for your time.
Thank you very much. Are there any questions? Yes, Graham. Yes.
It's just again about making the links across, because we've heard here before about the family hub development. That's absolutely about early intervention and dealing with inequalities, and we'll be picking up a range of these similarly across to the safeguarding partnership. So I think how we pull this together, I think we can see all the links happening and just make sure we focus and get the reporting in the right place, I think.
Thank you. Right, if there are no other questions, thank you very much, Karen. And we will move on to 7th item, Northumberland Inequalities Roundtable. I think Graham is going to lead on that, followed by Jill, I think.
Hello, everyone. I've sat very quietly today, I think. Yes. It's first time I've turned on my microphone.
I didn't make any mistakes too, so that you can point me out.
So the point of this bit really is to highlight the forthcoming roundtable event that we're going to have. And I'm going to pass to Jill in a second. But I'm actually sitting here thinking, wow, because I've just witnessed a conversation between the police service and the fire and rescue service in front of all of us talking about inequalities and prevention. And so I did actually write a list of the language that I've heard today. I've heard prevention, person-centred, inequalities, equality, community, safety. Young people have been quite a focus, but we've mentioned carers, older people, and vulnerable people. So the language here has changed. And I think that reflects a change in culture, which is coming, but you have been at the core of that, I think, because the inequalities plan stemmed from here and signing up to it. Okay, so that's amazing for me. I suspect in the past we would have talked about patients and services much more. We would have been much more focused into that about our discussions here. We have talked about services, but the main focus of that discussion was the impact of a service change and who might be more adversely affected. So thank you to Derry for that. So it's 1 year on since we had our Inequalities Summit. There are some thank yous to be had. I think he's just left, but the leader of the council, I think, has set direction and given us challenge. And I think that's been a lot of what we've done this year has been a challenge to do something about it and set an inequalities plan, which was done. I've been fortunate to chair the inequalities group, but actually chairing is the easy part, I think, of that. And Jill and her team and the people that have been brought in behind. So I'm going to mention Karen McCabe especially, because she has worked extremely hard on this and has actually made a big difference to how we've progressed things. But she's not the only one. I'm aware it's a bigger team. And then I need to thank the other members who come and the continued support to that. But the next bit really is a challenge because we've only come a tiny bit of that journey. We've done a lot, but actually, as we knew at the beginning, we're not going to reap the rewards of this work potentially for a long time. It's the younger people that we're going to have the biggest impact on, I suspect. So the idea of the round table, I've put reflect, reassess and refresh. Okay, because I think we need to actually look with a critical eye about where we've come from and what we've done, but then decide, are we still on the right tack? Do we need to change what we're doing? And how do we actually continue to do what we've done? So I'll pass to Jill. Thank you.
I never like following Graham because he's so articulate. Thanks for that, Graham. So this is just a bit of a promo advert for people. We've looked at diaries and we've managed to secure Cormac Russell to come over in person from Ireland for the Inequalities Round Table and to try and capture people's diaries in quite an overt way. We're proposing to stand down the 13th of July Health and Wellbeing Board and have our Roundtable Inequality session on that day, but to extend it. So it'll be a 9 till 2 that'll come out into people's diaries, purely as a hold the date for now, because we're still working as a system of partners on what that agenda looks like. But as Graham has said, we're really keen to take a critical reflection back and celebrate the wins and what's strong in Northumberland without a shadow of a doubt, because we've got some fantastic early wins over the last 12 months. And also Cormac will work with us as that critical friend to say, that's great, and what next. And I think that's going to be really important for us. And I think as well, as we've started to land as infrastructures in the local authority, within the NHS, it's now time, we think, to potentially blend that stronger communities and asset work with some of the bigger policy work as well. So there's going to be quite a strong theme around people, place and policy coming together. And we know that some of the conversations that we've had over the last 12 months are around what about the Professor Sir Michael Marmot's work and the 6 policy objectives and the work that's within the Joint Health and Wellbeing Strategy. So that'll be an opportunity for us to consider how we do that strengths-based work and the policy work and bringing that together as a collective so that we're not bumping into each other across different governance systems and that we look at our finite resources and continue to pool them together as system influencers and as system leaders. So that's the bite size, hopefully enough to tease everyone to come along, because we all need your input, because this isn't about Graham and I, this isn't about the Inequality Steering Group, this is about everything we've heard today about us all walking the walk on this to make a difference now and over the next 10, 15, 20 plus years. So.
Absolutely. So I completely agree with Jill. This is for everyone to take part. So the date is Thursday, 13th of July, 2023. Please make a note on your diary. If you can be present on that day, we would be very delighted. Okay, so that then, thank you, Graham and Jill. That we move on to the 8th item, which is forward plan. And please note the details of forthcoming agenda items. If you have any suggestion or input, we will be happy to take it now, or you can email to me or Jill or Leslie. And then there are no urgent business, actually. So date of the next meeting will be on 8th June, 10 a.m. at this place. Thank you all for coming, for your contributions. Thank you very much.